Hello and welcome everyone to this Locomotion webinar about the health economic aspects of long COVID. I'm Claire Rayner and I'm one of the patient co-leads for our patient advisory group on this very large project. And I, amongst other patients, have been working with the health economics team, and in my opinion, this is just one of the most important aspects of health, basically. So, I mean, it really is the end result of everything we do in providing healthcare. So I'm very privileged to hand over to Joseph Kwan, who's going to talk to us about the work that they've done. And we also have Joseph Mensa and Professor Stavros Petrou from the Health Economics departments at Oxford, who have been supervising this aspect of the study. So it's really nice to have everybody here, and we will have time for questions and answers at the end. So please put them in the question and answer section and we'll try and attend to them at the end. So thank you very much, and over to Joseph.
Hi, nice to see everyone. I can't actually see anyone or see any chat box, so I might be able to hear pings, but please, it's not me ignoring comments as they come along. Please put it in the chat and then we'll probably address them at the end. So yes, as Claire said, there are two Josephs who did the main bulk of the work, myself and Mr. Joseph Mensah, who's a PhD candidate in Sheffield. And we've been working on the data collected through the Locomotion study. So for people who are not familiar with Locomotion itself, it's an NIHR-funded research project. It's a mixed method study seeking to optimize all aspects of long COVID care in the UK. Participants are long COVID patients referred to one of 10 long COVID specialist clinics in the following regions: Birmingham, Cardiff, etc., all the way down to Salford. Leeds is actually the biggest clinic with the most participants. Each clinic had a multi-stakeholder co-design of intervention models that they would implement, and which is unique to each region and clinic. So there's kind of a variation here across clinics, and one of the main question of Locomotion was to look whether this variation results in differences in outcomes in long COVID patients. So the three main questions we ask and seek to answer in this piece of work is: first, do the long COVID specialist clinics improve the health economic outcomes of long COVID patients? Two, are there variations in health economic outcomes across the regions and specialist clinics? And three, what can be said about the national health economic impact of long COVID? So this kind of maps onto the three study aims. First aim is to assess the factors associated with the longitudinal change in the key health economic outcomes, namely EQ5D5L and health economic costs of long COVID patients. And a key explanatory variable here is the volume and type of services received at long COVID specialist clinics. We want to see whether these influence the longitudinal change in these outcomes, and also whether it varies by which specialist clinic and region. Second aim is to assess whether the services received by long COVID patients respond to their health needs. So here the outcomes are volume of services received at long COVID specialist clinic and volume of outpatient specialist services, which are possibly outcomes of referrals patients received from the specialist clinic, but not necessarily so. We want to see whether these services, elective services, are essentially being driven by health needs faced by long COVID patients. And a third aim is to estimate national health economic impact of long COVID using extrapolation. The population is long COVID patients participating in Locomotion and referred to clinics, as we mentioned. They're all registered on the LROS digital platform between 1st of June 2021 and 13th of September 2023. On the LROS platform, there were three digital patient-reported outcome measures. The three main ones we'll be using today is EQ5D, Health Economic Questionnaire, and the COVID-19 Yorkshire Rehabilitation Scale, or C19-YRS. So from these questionnaires, we get kind of three main groups of health economic outcomes. First is the EQ5D health utility. So for those not familiar with EQ5D, there are 5 dimensions. That's the 5D aspect: mobility, anxiety, pain, self-care, usual activities. And each dimension has 5 levels. That's a 5L bit. And then it gets transformed into what we call health utility or utility index, which is a single figure. 1 is the maximum for full health. 0 represents kind of health state equivalent to death or perceived to be equivalent to death. And then you also have health states with utility less than 0. So there's that health states deemed worse than death. And they're kind of value sets which transform the dimensions into utility index, but we don't actually have one for the 5-level versions of EQ5D, but we have something that can map it from 5 level 1 to 3 level 1. So we'll be using EQ5D3L utility index as a key outcome. And health economy is like this because we then use EQ5D to calculate stuff like quality adjusted life year, and we assign monetary value to that. We'll get into that in a bit. Second group of health economy outcomes is health economic costs incurred in the public sector. So this is service received at long COVID specialist clinic, outpatient specialist services, A&E and other secondary care, inpatient care, community health care, majority of them are primary care, social care, and NHS prescribed medications. So we had kind of utilization across these categories, and then we use unit costs to kind of value them, and so we get the kind of the monetary value at the end of it, which is public sector cost. And then we had what's called societal costs. So these are outside the public sector, often hidden, not very well observed. The first kind of big component of that is productivity loss. So relative to before long COVID, we want to see what's the reduction in people's paid working hours and reduction in their paid work income, with which we can calculate the loss in the productivity relative to before COVID. And then informal care receipts. So we assume that each hour of care received from family or friends, it can be costed in the market price of receiving care from a private provider of care. So that's kind of a proxy goods method of valuing informal care. So those two comprise the societal cost that we'll be looking at. So the covariates, the things that might influence the relationship between outcomes is first big one is C19YRS. This has four subscales: functional disability, 0 to 15, and higher the score means worse disability. Symptom severity 0 to 30, higher means greater severity. Overall health 0 to 10, higher score here means actually better health. It's the other way around. And other symptoms 0 to 25, higher score means worse symptoms. And this is a long COVID specific health measure that's been validated. So it's a good indicator of health status in long COVID patients. And then there are various social demographic and COVID-19 history variables: age, sex, ethnicity, region. That was the key question, key variable. Remember, IMD quintile, duration of long COVID, and hospitalization due to acute COVID. And unless specified otherwise in this talk, all the regression models are just for these social demographic and history variables. The key hypotheses are, in the longitudinal analysis, we only do complete case analysis here. Do the 3 outcome categories, EQ5D, public sector, societal cost, are they associated with greater number of service types received at long COVID specialist clinic? So are they associated with greater intensity of care, essentially? Second hypothesis under this is that there will be regional variation in the outcome trajectories. On the second aim of analyzing service utilization patterns, again, it's complete case analysis here. Outcomes are number of specialist clinic services and number of outpatient specialist services. We want to see whether these are associated with greater health need measured by EQ5D and C19YRS. And we also want to see whether there's regional variation in the utilization patterns. On the third aim, we are using extrapolation to estimate the national impact. There are 3 outcome categories: loss in quality adjusted life year, calculated using the EQ5D, relative to the general population peers of same age group. So general population peers have relatively high EQ5D, and in long COVID patients have relatively low EQ5D, assuming that they're going through the same life years, so we can calculate the life years adjusted by the different quality of health-related quality of life of these two groups, and the difference is the loss in QALY. And we can actually monetize this using the nice threshold of about £20,000 per QALY loss. So that gives you a monetary value of the QALY lost relative to general population. Public sector cost is kind of absolute amount incurred, and societal cost, as I mentioned, is absolute level of productivity loss in formal care cost. And then we make some assumptions on how these outcomes change over time. So the Locomotion study starts, but people already have been living with long COVID for a while, over a year. So we assume that the whatever the impact is measured at the baseline, we can project it backwards to the start of their long COVID. And then there's the longitudinal trajectory during the Locomotion study, and then what happens afterwards. Well, on the scenario 1, we assume that the trajectory we observe is maintained until 7th of March 2024, and that date is the end of the data collection for the ONS survey, the winter coronavirus study that we'll be using to extrapolate the impact to a national level. That was the date when it was last measured. So we assume that from the end of Locomotion's observation, the final observation, to 7th of March 24, the longitudinal trajectory is being maintained. And the second scenario is that it's not being maintained. The trajectory is not being maintained. So the final observation, whatever the value, the impact, that's kind of maintained until March 2024. And as I mentioned, the extrapolation to the national level is done using the ONS data. And here, there's a subgroup within the ONS survey participants who report a lot of functioning difficulties due to symptoms. And there are about 360,000 of them nationally in England and Scotland who are aged 18 and over. And we'll be assuming here that the Locomotion participants are representative of this subgroup in the national population. So let's go to the results. Let me just check the time. Yeah, I think we're doing well. There were 2 main samples, and there were different samples because the data collection was being done on different questionnaires, and it was kind of done separately in the LRS platform. So that introduced a bit of a distinction, so the data set has to be kind of merged together for analysis. So you see that EQ5D sample had about 1,600 people at baseline, HEQ health economic questionnaire about 730 at baseline. They're similar age. There's a bit of a difference in the regional spread across the 2 samples, and also some difference in the mean long COVID duration. And unfortunately, there's quite a bit of missing data for IMD quintile, which is derived from postcodes in the EQ5D sample. And this might be because EQ5D was being collected quite early on in the study. But the health status between the 2 samples were quite similar as measured by EQ5D and C19YRS subscales. So concerning the first kind of aim of the study, so looking at the longitudinal trajectory and what influences the trajectory, we had 2 or more observations with which we can calculate longitudinal trajectory from about 790 people in the EQ5D sample. And the mean interval between the 2 observations, the first and the final observation, was about 185 days, so about 6 months. And overall, of course, the whole sample, the mean change was about 0.028 on EQ5D, which is different from 0, but it wasn't clinically significant. So you have to be 0.03 to be deemed clinically significant. This multiple linear regression adjusts for all the covariates in the COVID-19 history variables I mentioned, but I just highlight here the kind of the key variables related to our hypothesis. So if you look at the kind of model 1, you see the whether the trajectory varies by region, and the answer is not really. So Leicester kind of approaches statistical significance here, where essentially saying compared to Leeds as the reference group, Leicester is having kind of worse EQ5D improvement over time, but it's not. It is kind of right on the borderline of significance. When we additionally adjust for number of long COVID specialist clinics, so that's one of the main hypotheses. We don't see any association here. So higher number of services is not resulting in better improvement in EQ5D over time. But in the third model, we adjust for change in C19YRS subscales, and it's interesting to find that, as you might expect, better improvement in C19YRS is resulting in better improvement in EQ5D. So there is some change, in predictable change, but it's not associated with intervention. Second and third group of outcomes is the health economic costs, the public sector costs and the societal costs. And here there was high attrition so that we could only have longitudinal change from 269 participants. And the mean interval between observation was about 120 days or 4 months. There's a mean decline of about £290 per patient per month, monthly cost. And this change was significantly different from 0. So let's just break it down into cost categories, cost types. So this is the breakdown at the baseline. So on average, each patient was incurring about £1,700 per month. And you can see that the biggest share of that is taken up by productivity loss, about £700 per month, followed by informal care cost. And those two together constitute about 2/3 of the overall cost. And then public sector cost is kind of broken down into different categories. And the biggest factor is the outpatient specialist services, followed by the long COVID specialist clinic services. And this is how they change by the time of the last observation. So that's overall it's about 1,400 per month, so dropped by about 290 as I mentioned. And there's actually an absolute increase in productivity loss from 700 to 800. The productivity loss actually got worse, both on the absolute level and a relative level. There's a slight drop in informal care costs, but the percentage share of it has actually gone up over time. There is a massive shrinkage in public sector cost, and most of the shrinkage is driven by public sector cost. And particularly in outpatient specialist services. So it's gone down from 230 to about 79 pounds per month. So use those as outcomes in a regression model. So let's take public sector cost first. The sample size drops further when we merge it with EQ5D, unfortunately. Interesting relationship here is that the number of long COVID specialist services, the more number we give, it results in a significant drop in public sector cost over time. So this is quite an interesting thing and quite difficult to interpret, actually, particularly because there's no association with change in EQ5D and public sector cost. So it appears that this drop in public sector cost, or this association between number of specialist services at baseline and change over time, is not being driven by change in health. So it's an interesting one, and we'll have to discuss in a group about how to interpret this. Anyhow, the second hypothesis is there regional variation in public sector cost change? And here again, no, we don't see quite regional variation in the trajectory in public sector cost. We don't see association with number of specialist clinic services and societal cost. So productivity loss and informal care cost is not budging. It is certainly not dependent on number of services. And it seems like the association for the total health economic cost, which is these two added together, is being driven by public sector cost. And in none of these models is there association between region and change in EQ5D index. When we, instead of having number of specialist services, we break into different individual types of services. we actually see some differences in what services are associated with trajectory in cost. So let's take public sector cost again. Societal cost is not associated with much with any of these service types, unfortunately. But the public sector cost, there seems to be some variation. Some services are associated, some services are not. But generally, it's quite hard to interpret these numbers again. For example, sleep management is associated with about £3,600 greater drop in public sector cost. I'm not quite sure how to interpret that. But anyhow, the key takeaway is that there seems to be some discrimination between what service people are receiving and the public sector costs over time. Although people are receiving, they could receive combinations of these. So this is indicating people received a given service, at least as part of the package they're receiving. Right, so that addressed the first aim of the study. Moving on to the second aim of whether service utilization responds to health need. Here, just kind of doing basic descriptive study stats here. So this is kind of a graphical display of what services are being given and received in long COVID specialist clinics across the 10 regions. Unfortunately, we don't have data for Highland in Scotland, so it got taken out. So 9 in this case. So you see that the regions and clinics differ in the mix of services they're providing, but the uniform trend is that they're giving out less services over time, except for Leeds and Salford. So this is the similar graphical display for outpatient specialist services. Again, we see some regional variation in the service mix, but also a uniform trend in people receiving less outpatient services over time, and we saw this in the cost data above, except for Salford again. So let's put this service utilization pattern as outcomes into regression model. Here we're using mixed effects model, where instead of just using people with longitudinal data, we are creating kind of a quasi cross-section that squishes in all the longitudinal observations into kind of one cross-section, and then having mixed effects for individuals. So we are counting for repeated measures per individual, but we are analyzing at a cross-sectional, as if it's a cross-sectional data with these covariates as the fixed effects. And again, this adjusts for other covariates, social demographic and COVID-19 history variables. But let's look at the regional variation. And interesting here that there seems to be some evidence of regional variation in number of long COVID specialist clinic services received and given out. So references here Leeds. So it seems like Imperial, Newcastle, and Oxford are giving out significantly more services given health need. So the three models here have different measures of health need. So in the model 1, you have EQ5D3L index as a measure of health need. And you see that services are reacting to health needs. So higher index means lower health need, and correspondingly, there's lower number of services being given out. So this is an incident rate ratio. So anything less than 1 means less number. Anything more than 1 is a greater number. So better health, less services. When we adjust for the dimensions rather than the index of EQ5D and mutually adjust for each other, you see that anxiety and pain appear to have a particularly close relationship between number of services given out and worse health. So in the dimension level, higher value means worse health in that dimension. So more anxiety is being responded to by more services at the long COVID specialist clinic. So here we see that mobility, self-care, usual care are not associated, but that's because they are mutually adjusted for each other. When we include this as separate covariates, we see here that they are. So they are all associated significantly in the direction we would expect. Just that, in this, when we mutually adjust for each other, is saying, given anxiety, pain, self-care, usual activities, does more mobility lead to higher healthcare use, and is not sensitive to that level. In the third model, we're adjusting for C19 virus subscales. And here, when we mutually adjust for each other, there's no significant relationship with service utilization level. But when we include the separate covariates, they are associated in expected directions. So worse functional disability, worse symptom severity, worse other symptoms means more services being given out, and in the opposite direction for general health. A really interesting variable here is health economic questionnaire sequence. So here it means greater the number, the more later on it was responded to. So the baseline response has a value of 1, second response per individual has a value of 2, etc. So all the way to nth response, and with value n varying by individual. So on average across individuals is saying that the later response, i.e. passage of time, is showing less services being given out across individuals, having adjusted for region and health need. So there appears to be what I call secular decline in healthcare utilization over time. That's not quite explained by measures of health need. And again, we need to interpret that carefully. I've done that. And I do the same analysis with the outpatient specialist service utilization. And we see here that the regional variation is even more marked for outpatient specialist services. And the general picture is that seems like any region other than Leeds appears to be giving out more outpatient services than Leeds. Well, not all of them, but 6 of them in this case, when we adjust for EQ5D index, that is. And you see that the dimensions and subscales are not strongly associated when we mutually adjust for each other, but they are when we do it separately, except for general health measure in C19-YRS. And we again see this secular decline in service utilization over time. The last study aim was to estimate the national impacts, and here I just lay out the results. So we can break down the impact. So this column is the national prevalence. So that's the data from the ONS. And when we do the trajectory estimation and extrapolation by age group, this is the extrapolated impact by different outcome categories. So the monetary value of quality loss for people less than age 35 is about £1.6 billion. 1.3 billion pounds in terms of public sector costs, and about 2.5 billion in terms of societal cost. And then about 5.3 billion added all up across the outcome categories. And then if we annualize it, it's about 1.8 billion for this age group, and we sum it up across age groups. Sorry, I think I skipped a slide. Sorry, yeah. So this is a base case estimate of about 24 billion nationally, from start of long COVID to 7th of March 2024. If you annualize it, it comes out to about 8.1 billion pounds per year. And here the percentages show the breakdown, the components of the total impact by the outcome categories. So societal cost expectedly comprises about 56% of total burden. Quality loss about 25%, and so forth. And here the second table is under the scenario of the trajectory not being maintained after loss of elevation. It doesn't make too much of a difference, so the estimate falls to about 23.7 billion under that scenario, and annual cost about 7.9 billion. In this slide we're doing some kind of sensitivity analysis, so we're allowing the trajectory to vary according to bootstrap confidence intervals. So here we are using 2.5 percentile of the trajectory, so which gives us a lower bound of the estimate, and it comes out about 17.8 billion in the aggregate and about 5.9 billion in annually. And if you use a 97.5th percentile, is about 37 billion and 12.4 billion annually. Okay, so to summarize, were the hypotheses met? How are we doing for time? Okay, I think we're doing fine. The hypothesis concerning long-term analysis. There was no evidence that higher number of long COVID specialty clinic services as a measure of service intensity is associated with better improvement EQ5D index. Although we did find as a corollary that C19 virus subscales are associated with change, which kind of gives us hope that addressing the long COVID specific domains of health may lead to improved EQ5D outcomes over time. But that's not quite reflected. Well, I mean, on average, it increases by 0.028, but it doesn't seem to appear. It doesn't seem to be associated with intervention effect. There is, however, evidence that higher number of clinic services is associated with fast decline in public sector cost, though not in societal cost. And this is differentiated by the service type taken individually. But this was not associated with change in EQ5D, so change in health. So it seems to be a reduction in service utilization and cost that's kind of independent of change in health. So kind of interpreted charitably, it could be that high intensity of long clinic services is reducing upfront the need for wider healthcare consultations over time. So you could interpret this as intervention effect and long COVID services kind of reducing the care needs elsewhere outside long COVID specialist clinics. Or it could be evidence of unmet healthcare need that increases over time. Unmet need which is not being captured by EQ5D index. Concerning the second hypothesis of regional variation, we found no evidence of this. And this was done both controlling and not controlling for a number of clinic services given out. For the hypothesis on the second study aim, about service utilization pattern, there was evidence that clinic services and outpatient services are responding to health need according to the measures we used. And there was evidence of regional variation in service provision. And this variation remained after controlling for health need. That said, the variation did not translate to difference in outcome trajectories as we saw above. So how do we interpret this? In general, as you mentioned, non-lease clinics are using more resources, having control for health need. So could this be overutilization resources in non-lease clinics? Or there could be some health needs that are not captured in the measures we're using, in which case we could say there might be some unmet health needs in the lease region, which should be addressed by more services. An interesting finding was that there was a secular decline in service receipt volumes after controlling for health need across all regions. So again, this could be just a drop-off in service volume until the next intervention cycle. So remember that the interval on average about 4 months. So it could be that people are receiving lots of services at baseline, and then the service utilization kind of drops off after that. But then we might expect that to kind of rise up again, maybe in a year's time, when a new intervention cycle begins, if it begins at all. So it could be that, or it could be that patients' needs are increasingly unmet according to some measure of need measured by some measure other than C19-RS and EQ5D. What do you make of the health economic burden of long COVID? First of all, let's focus on the EQ5D level rather than the aggregate impact. This still remained 0.559 on average at final observation. This is very low. To put this in context, this is lower average value of EQ5D than about pretty much a majority of diseases categorized by ICD-9. And diseases with higher EQ5D value include brain cancer, schizophrenia, and acute myocardial infarction, heart attack. So this is a very low level, and it has remained low. And unfortunately, we don't see a protracted, clinically significant increase in EQ5D level over time during the Locomotion study. When we extrapolate this value out to nationally, the monetary value is substantial, to put it mildly, about 2.1 billion pounds annually. Kind of put this in context, kind of entire cancer research budget annually is about 600 million pounds. So just for health loss associated with long COVID, it significantly outstrips that rich research amount in cancer, and it comprises 25% of the total health economic burden. Coming to societal costs, this was certainly the largest category of health economic burden, and this is driven particularly by productivity loss. Our estimate in this study is in the same order of magnitude as our previous estimate using preliminary data from Locomotion. The preliminary data you estimate about 5.9 billion annually for productivity and informal care cost. In this study, we estimate about 4.6 billion, so a bit lower, but on the same ballpark. Concerningly, while EQ5D improved marginally and public sector costs fell, although we don't know whether they fell for the right reason, societal costs remain largely constant. So this is quite a big worry. So that we don't see improvements in people's vocations and burden on informal caregiver burden over the course of the study. So really, the long COVID care strategy looking forward should particularly focus on vocational rehabilitation and also focus on the burden placed on informal caregivers. And likewise, economic evaluations of those long COVID care strategy. If we exclude that, if we only focus on public sector cost, you would really be missing out about 2/3 of the cost, or even three quarters of the cost if you just do it from a public sector perspective. So this study contributes to a growing body of literature evaluating outcomes of long COVID rehabilitation. Yeah, I think I have time to go through this, or maybe not. So I highlight here 3 studies we identified from systematic review that we also conducted. And kind of key takeaway is that these other 3 studies have demonstrated a significant improvement in EQ5D. And in fact, a 3rd study, which is quite large sample size, managed to demonstrate improvement in EQ5D, clinically and statistically significant, and reduction in GP outpatient consultations, and reduction in number of sick days, so productivity loss as well. And they appear to have similar kind of patient mix, but really I think we should have a close comparative look at whether service model Locomotion and the patient mix in Locomotion is comparable to this study. That could be a good project. So some limitations of this study. There was a high longitudinal attrition, and this means that the regional variation question particularly might have been underpowered to detect. There was variation at individual level in the time interval when people responded to the digital questionnaires, and this created a lot of noise in trying to estimate longitudinal patterns. And there was some attrition when we tried to merge data sets. Next time we shouldn't have separate questionnaires. Yes, and a longer follow-up interval would have been ideal. So longer than 4 months for health economic questionnaire, about 6 months for EQ5D, although that was actually longer than the previous studies. And here in this question, we are purely kind of statistically driven. We don't explore the details of why particularly service utilization patterns are so different across the long COVID specialist clinics and regions. So it'd be nice to explore some of the underlying reasons why we are seeing differences across regions. But the study has some key strengths. Locomotion sample is a mixture of hospitalized and non-hospitalized long COVID patients, and we don't actually see hospitalization as a significant factor determining utilization patterns or longitudinal trajectory and outcomes. So it appears that hospitalized and non-hospitalized patients are facing broadly similar care needs and health prospects. I think that's an important finding. Our study does have a comparator across the regions. They served as their own respective controls. And again, once we have the underlying theory of the differences in regions, we could possibly draw out some causal patterns. And most importantly, the questionnaire-based collection of data means we could estimate the societal cost. As you mentioned again and again, this occupied the largest component of the health economic burden of long COVID. And the national impact estimation we draw out really illustrates the scale of the issue of long COVID and really should motivate national action. So thank you for listening. We'll be trying to answer any questions you have.
Thank you so much, Joseph, for presenting that. It's been fantastic work, and we're really grateful as patients to the whole health economics team. I just want to say a few things in summary from the patient perspective, and then hand over to people for questions and answers. I'm an occupational physician by background, and I wrote a paper for the British Medical Journal in April 2020 predicting the economic impacts from the point of view of work. And here we are. And I think what the health economics work package have shown here is not just the national cost in terms of productivity and so on, but it's the only study to my knowledge that has also tried to calculate the impact on families and carers. And that includes parents looking after them with long COVID and so on. And we were, as patients, intimately involved in designing the questionnaires which looked at the impacts on people and families. I want to highlight that infection with SARS-2 virus does lead to several health problems, and we've got to assume those need healthcare in many cases. And we know we've got huge numbers of people with post-COVID conditions in the country and the world. There's been funding for long COVID clinics, but it's now not ring-fenced, and it's not necessarily reaching the right people. So I think we've got to be aware that the virus does cause and is associated in all the large epidemiological studies with various consequences that need healthcare. And these figures are pretty mouth-watering. So I think as patients, we feel that there remains a big unmet need to direct the right healthcare services at the right time. So I'd like to open it up to any questions that people would have.
Yes, we do have two in the chat already.
Oh, great, thank you. Let's have a look. Mine's a bit slow to come up. Would you be able to pick out any of those?
Sure. So the first one says, do you think the EQ5D5L is the correct measure for a fluctuating condition and a condition that can be so variable for people as it measures a snapshot in time?
Well, thank you for that question. I think the PPI group, we had long debates on the appropriateness of EQ5D, and focus groups we ran, this question comes up again and again and again, particularly things like dimension, like usual activities. Other than the fluctuation, that's the important issue, but things like what is a usual activity changes over time. So as people adjust to long COVID, what is usual becomes non-COVID usual rather than pre-long COVID usual. So there are issues around EQ5D, certainly. And it could well be that EQ5D, particularly when we looked at it as a covariate in service utilization, it might not be capturing important health needs. So particularly secular decline in this in the service utilization could well be unmet need, which is not responding to need not picked up by EQ5D. So, but it's important from national commissioning picture that there's some comparable outcome. And I'm sure if you speak to any health economists, they'll give this answer. But we wanted to really use C19YRS as well, and hopefully that would pick up long COVID specific health need too. And I think Locomotion, a couple of teams actually is looking at validity of EQ5D with reference to C19YRS. And I think both papers coming out relatively soon. In general, yes, and as people might expect, EQ5D is less sensitive to long COVID health status than C19-1RS. But also, it does seem to be valid, as you saw in one of the tables, where C19-1RS is longitudinally associated with change in EQ5D. So it's not a completely useless measure either. So you have to take it with a pinch of salt, but you know, from a health economic perspective, is a pragmatic decision you have to take. Yeah.
And from what I understand, it's recognised in all the circles of people and professions that look at economics. So it is a well-known and well-standardised measure. But we did, as Joseph says, have a lot of input into how that matched with patients' experience of symptoms and problems. And also, we were very much part of helping to design the economics questionnaire, which looked at these additional aspects as well and the impact. So we hope that the three measures combined give some, as best as we currently can, an idea of this fluctuating condition or progressive condition for some.
Yes, and actually, a strength. Sorry to throw in this question, but the strength of comparative, the ability to compare is things like long COVID patients have worse EQ5D than 229 or 270 disease groups. So it's able to demonstrate the severity of disease faced by long COVID patients, and we wouldn't be able to do that if every disease is using different outcomes. And so far, I think EQ5D has been good for long COVID. It's been
but I mean, that's a pretty shocking figure to see, or a fact to see, that, you know, at that level of 0.59 or whatever, that it's worse than most other health conditions. That's terrible.
There are some conditions where it's severe, but in terms of mortality and so on, but the EQ5D comes out really high. Important ones like congenital disease. So children born with congenital disease, they've never known a better health state, so the EQ5D level is very, very high.
Somebody asked, could the study be used to influence NIHR funding of long COVID research, and how? I mean, obviously the NIHR have put money towards funding these and other large studies, and NHS England and the devolved governments to the provision of long COVID clinics. But that funding wasn't ring-fenced from April this year, and we do know anecdotally that it's meant that it's not reaching the long COVID clinics. So that's a massive shame for patients, really. So I would like to think that health economics figures would be the thing that have an effect on government and research funding. That's my view, but have you any views as health economists on how this study might be used to influence funding?
I just got an email a couple of about a month ago from NIHR, very interested in disseminating the previous health economic work we did, which just looked at productivity and informal care cost. So because they recognize that paper is trending, so they themselves are interested in research that's going far. And you know, this paper quadruples the health economic impact measured. So hopefully the NIHR's interest will be quadrupled. Hopefully. So from NIHR's perspective, I think, you know, we're going to have an audience. Obviously, from a broader policy perspective, you know, we can't predict.
No, absolutely. That's a really good point. Yes, I'm going to read out the question here and see if any of you could answer this. Is it correct that the productivity loss represents loss of earnings? Does it include other costs for individual patients, such as reduction in savings, changes in diet and lifestyle due to loss of income, and additional costs of alternative therapies?
The productivity measures we used did cover things like people's unpaid work contributions, but it didn't go into savings and pensions. That's something we should definitely do in any forthcoming studies, because with the focus groups we ran, yes, I think the issue around not being able to work, no longer eligible for benefits, and people really running out of financial reserve to keep going was a major
Yeah.
theme. So
Yeah.
although we did have a question in for how severe is long COVID for your financial status. So it was kind of a
That's right.
1 to 5 kind of a subjective severity question.
Yeah.
So yes, maybe I should use
But
that.
to be fair, yeah, but to be fair, a lot this when we were designing, the details of it all was 2021, wasn't it?
Yeah.
And we're now at 21, 22. We're now effectively 3 years down the line from that. So these financial impacts are probably now more obvious. The ones on savings or other paying for your own healthcare, which is not so many people were having to do that at that point. But as 3 years has passed, the impact financially has got even worse for people. So
Yes.
I think it's a matter of a change in time, really.
And I think it's a strong value judgment that we always have pre-COVID as the benchmark. So we don't want to have, reference, how is it doing since last year? Anything could have happened since last year. We always want to see, how is your impact since, before your long COVID got COVID. So that's also a strong value judgment we made. Yeah.
Yeah, absolutely. Do we have any other questions? I can't see any in the chat. And the questions and answers.
Yeah, there are a few more in the questions and answers.
Oh,
So,
right. No, I'm obviously not guessing. Yeah, I'll let you have a look.
I think one was talking about asking, I think you've addressed it. Does this include wider cost to carers? Example, people leaving work to care for long COVID patients and their mental physical health suffering?
Yeah, so the health burden on the caregivers, no, unfortunately not. Again, that could be given the significant impact of former caregiver. For further research, we should consider that. We did include a question on their whether they had to give up job or something like that. So productivity impact of informal caregivers, but I think health is also an important one. Yeah.
Absolutely. Yeah.
It was a hard job trying to shorten the questionnaire, so we spent once. Yeah.
Yeah, because it had to be that people will keep filling it in at each interval as well. So well as all the other questionnaires they were doing. So it was trialed and tested a lot, wasn't it? As to what was usable and captured what we thought needed to be captured at that time.
Yeah.
Yeah, I think there are about 2 or 3 left.
Okay.
This one is more of like a comment or question. So the person says, given the persistent psychologizing of the condition, good money has repeatedly been spent on this patient group mental health, whereas the physical condition is the cause of poor psychological well-being. Trying to help us think more positively does not appear to have made improvements in the physical and practical problems of long COVID itself. Who should be accountable for these wastes?
Ooh.
I don't know.
I just did the numbers.
I agree.
Yeah. Yeah, I'll get into trouble if I make comments there.
Though. Yeah.
Yes.
I couldn't agree more as a patient and as a representative of patients that this is a physical problem. Patients sometimes express some patients would like psychological support to deal with the significant impacts of a physical condition, but it's not primarily a psychological condition. As I said in my little summary, there are a number of conditions and problems caused by the SARS-2 virus that need properly investigating if somebody has persistent symptoms. We have guidance on that. There are symptoms which can be treated. There are organ damage that can be treated or supported. There are also higher rates of autoimmune disease like diabetes developing. We have to watch out for those new conditions. And there are significantly increased rates of cardiovascular complications and so on and so on. So there are conditions and they need treating properly physically. I don't know who's accountable at the end of the day. I can guess, but
Yeah, and just I think you can use this to lead to the other part, but this question says, will you conduct a qualitative study assessing how clients have been assessed and their treatment, etc.?
Yes, so biggest kind of gap in the health economic team's knowledge is that, as I mentioned, we haven't yet done an in-depth analysis matching the numbers to what's been going on in service clinic level. Unless the qualitative study you want with patients, but certainly there are some qualitative research done at the clinic level to understand the theory of change and so on. So I think trying to match these numbers with that would be an important part. From patient perspective, yes, absolutely. And in fact, we did a couple of focus groups while the questionnaire was being rolled out, and things like the savings and pensions question came up, and it was really deep, eye-opening experience to have focus groups with long COVID patients. So should further research occasions arise, I think definitely qualitative research to design questionnaires, design care evaluation strategies. Yes, absolutely.
We're hoping at the end, I mean, we are at the end now of Locomotion, but the patient advisory group and some of the researchers are writing a qualitative paper on some of the things that we've gathered within Locomotion. So we hope that will be an output. But I think there's always options for future qualitative research, and that needs to be captured. Was there one more question, Joseph? Have we got time for that, Joseph?
I think there's been some conversation in the chat and the Q&A, but I think those are the main questions that have been addressed. Yeah.
Okay. Great. So I think we're on 4 o'clock. Thank you so much, both for your presentation today, which was really interesting to hear, but also to all the health economics team for their work on this. And really, truly, it has been an excellent example of patients and public working together with you, and I think come out with some really important conclusions which need to be food for thought for people that fund and organise services, really. So thank you very much, and thanks to everybody for attending.
Thank you. Thanks, Claire, for chairing, and Joseph too for your work.
You're welcome. You're welcome.
Thank you.